This is Michael Saltzman from Blue Sky Bio. I'd like to take this opportunity to welcome everybody who's joining us for tonight's presentation. This is the next presentation of our 2018 webinar series. We have a variety of upcoming presentations as well, where we're going to be discussing actually how to take a lot of the clinical discussions and techniques presented in these webinar presentations and how to actually perform the step-by-step process flows in the Blue Sky Plan software. So the information's on the Blue Sky Bio website, and you can register and get more details and information there. And I'll be giving most of those presentations, so I look forward to seeing you there. As usual, if you have questions during tonight's webinar presentation, please enter them into the chat box, and we'll try to have them addressed during the presentation. And in the chat box is the link or the webinar attendance form. So complete your details in the webinar attendance form so that we can send you the CE credit. And that usually arrives via email within around 1 week of the presentation. Tonight's presentation is a presentation that personally I've been looking forward to as well. There's been a lot of discussion about endodontic techniques in the Blue Sky Plan software, and I'm looking forward to learning the proper way of having it done. And at this point, I would like to welcome the presenter of tonight's webinar presentation, Dr. David Kelliny. Without any further ado, please go ahead.
Hello, everyone. Hopefully you haven't had a rough day so far, and we get together to discuss 3D endo guides in Blue Sky Plan. I get a lot of questions about utilizing the software and how to plan endo guides, both for endodontic access and for surgical guides. We're going to go through a few clinical cases and show you guys what I have been working on for the past 2-3 years and how I utilize the software in performing these cases. And at the end, we would have a few minutes, hopefully, to answer any questions and go over any concerns that you may have. First, we're going to start off, but what do we need as far as to prepare for planning for the guide as in Blue Sky Plan? First, we need the software, and before I have to give a heads up that Blue Sky Plan has been an amazing software. Before that, it was really impossible for us to work with any other software to plan for endo because it did not allow us the freedom to place implants or angulation or plan for an endo guide or create a guide that is not normally planned for an implant. Once we had that freedom with BSP, I was able to create guides for endo, and I was able to clinically use it test it on my patients, and it proved to be extremely accurate and amazing. It's been a great 3 years learning experience for me, and it's been a blessing and a change in my practice. So you would definitely need Blue Sky Plan as a software. You would need, with the current system or the current settings and available drills on the market, unfortunately, you have to create 2 guides to accommodate the limitations of the available drills. And the available drills, they're called Muntz burrs. Not many general dentists are familiar with them. They're usually used in endodontics, and I will show you a picture of them and explain to you how we plan for it using these burrs. You need a guide with a guide hole tube that will accommodate these burrs. One of the limitations that we have at this point is there is no guide tube, a metal tube or sleeve that would accommodate these burrs. So far, I've only been able to use this without a sleeve. Then you need the 3D printer. My preference and my to-go-to printer would be the Moonray. I know a lot of you love the form labs and they're used to it and may have it. The problem with form labs is you cannot print under 100 microns, at least not that I know of. With the Moonray, you can print down to 20 to 50 microns. Now, that difference in if you're doing aligners, ortho aligners, or printing for general dentistry, for the most part, it's not going to make any difference to you. But when you're drilling for endo, every little micron counts and makes a huge difference. The problem is, as you go deeper in a tooth, you have to go smaller, and as your drill gets longer, your deviation becomes more exaggerated and you can have problems. And then after you create the guide, you have to go through the post-processing, the post-printing processing. You have to do the alcohol bath, and you have to do UV light curing. Blue Sky Blue Sky Bio just released their light curing box, which looks amazing. I'm looking forward to try it and see. It's definitely way better than the way we've been doing it with the two um, nail curing units put together. This is our first case, patient number 1. This is actually taking a panel taking out of the CT scan. We are concerned with this tooth right here. It's tooth number 26. The patient had history of periodontal problems. She's an older lady. She did not want to lose her tooth. She did not want to lose that bridge, and she could not afford going through implants, even though she has an implant on tooth number 19 space and actually has another implant on the top. This is actually not a bridge. This is a lingual metal plate that works as a periosplint. That periosplint is holding. It used to be holding those lower front teeth together, and over the years she developed more perio disease and she lost those two. Periodontists kept on cutting them one after the other. Now that plate is totally holding off on those two laterals there, whether on and the canine here. Tooth number 26 came symptomatic. Patient has a periapical infection. The problem with that case was there was a composite placed in the canal path, and it had moderate to severe calcification. So in order for me to drill through the metal, the lingual plate, the splint, drill through the metal, drill through the tooth, drill down past the composite area, which is this white area right there, blocking the path of the canal, that normally would take an endodontist anywhere from 45 minutes to an hour, and we would have to sacrifice a significant amount of tooth structure above that level of composite and through the composite until we're able to find the canal. This was my very first case to utilize an Endo Access Guide. So this is, again, preoperative x-rays showing the composite blocking the way inside to the canal. Same here, different angulations. We took the CT scan to verify the canal location and the blockage, and you can see here the canal has receded, actually receded away from the composite, and it's blocked right in the way there. You can see on the bottom here how it's calcified above and below the composite area. These are the models. The way I do it, there's several ways of bringing in this data in. You can have an STL from an intraoral scan. You can have you have a scan of a model, or you can take a CT scan of the model, which is my way to go for bringing in a model into the Blue Sky Plan software. And if you notice down here, I had to block all the undercuts underneath that stay plate with wax, and that's why it looks funny in that area there. This is an occlusal view, and it shows you the line demarking the lingual plate. And this is the lingual plate. Again, this area is blocked with wax, and this is the metal lingual plate, or the periosplint. This was my very first case done about 3 years ago, and I used the Robox. I'm not sure if a lot of you have had the chance to work with it. It's an FDM printer. It's accurate down to, I printed with Dr. Rick Ferguson's profile for surgical guides. Its accuracy is at best 100 microns, and so that was my very first created guide for Endo Access. Again, this is one guide hole tube there, no metal sleeve as a limitation, and these are different views as it fits on top of the model. Now, the problem with using the Robox and 100 microns is not good enough for me is, as I was drilling through the guide, after I removed the guide, placed the dental dam, and I looked under the microscope, this is where I found my canal. The burr mark, or the drill marks, looked like this, and I had already started deviating, but the canal was on the facial of my drilling path. So if the canal was deeper, if I did not stop and check before, and I had continued going deeper in that same path, there is more deviation. I may miss the canal, and I may end up perforating. And that's when I decided, Robox and 100 microns are not good enough for this. We have to look for something more accurate, can print to a higher accuracy, and we can go down to 50 or 20 microns. And that's when we stumbled on the Moonray, and we started using it in dentistry. This was my master cone after I was able to drill through it and get to the canal and find it. This is the final outcome of the case. Now, this is patient number 2. This was a 27-year-old female with history of trauma on tooth number 9. When she was 9-year-old, the main concern was that the tooth discolored, and her dentist suggested the root canal and internal bleaching or crown restoration. Patient did not want to have a crown done. She requested to do bleaching. Now, to treat a tooth like this with moderate to severe, this is actually severe calcification. When we clinically go in as endodontists, drill through to try to get a canal like this, sometimes it can take us anywhere from half an hour to an hour, sometimes 2 visits, until we're able to locate this canal and treat it properly. At that point, I had my Moonray, and I was printing Endo Access Guides, and I tried to utilize that for her in that case. These are preoperative radiographs, a little bit more clear than the panel showed before, and it shows the extent of calcification in the chamber and the canal on tooth number 9. So how do we plan for a case like this? Usually I take a CT scan, I import it into Blue Sky software. We need a model or an intraoral scan, and import that one in the model. We overlap them just like we're doing for implant surgery, for implant placement. And then we start planning for a custom implant. So the way I do it is I create a custom implant from the edge of the model or my entry point onto the tooth to the point where I believe I'm going to catch a canal there. And that would be my total drilling depth inside the tooth. And then add to that the offset, and usually we would plan it directly right on top of the incisal edge. So your drilling depth, we try to minimize the amount of drilling depth because the drills that are available are actually short, they're not long enough. So you have to minimize the offset and bring it as close to the drilling point as possible. That will also minimize your deviation as you go deeper and as you put pressure on your drills. And then you make sure from all directions you fit on it mesiolingually and mesiodistally and buccolingually. And in that case, I decided to give it a test drive. What we did is I took the models and I scanned it, and I actually printed the model on the Moonray, and I did a test drill. I brought in my surgical guide, and as you see here, I had to print 2 guides on the Moonray with 2 different access holes to accommodate the 2 different diameters of the Munzbur's as I get deeper inside the tooth. Usually we would start with the smaller diameter guide and then move on to the longer diameter guide as we go deeper to accommodate the shaft of the drill. So what I did is I created the surgical guide and I verified its fit, just like we do with implants. And these are different. These 2 pictures would show the fit bit of the same guide on the model and on the resin model, and it's pretty accurate. This is the guide hole tube that we're gonna have to drill through, and these are the drills that we use. Those are the only available drills that are stiff enough for us in dentistry at this point, or in endo, that we can actually utilize to drill through a guide and through a tooth. They come in 2 different sizes, length. First is the short one is 31 millimeter long. The second one is 34. So the difference is not much. It's only 3 millimeters, but 3 millimeters in endo and getting it to a canal can be a big difference. They come in a set of 6. The first one is a quarter, a half, 1, 2, 3, and 4 sizes round burrs. The nice thing about it is the first 3 almost have the same size shaft. As you go to size 2, the shaft gets thicker, and we mostly utilize the first 3 because as the shaft gets thicker, you would need different sizes with the access hole inside the guide. For the most part, for Endo Access Guides, we only use the first 3. And the first one, which is the quarter, is actually a 0.5 millimeter sized round burr, and the half is actually a 0.6 millimeter sized round burr, and the 1 is actually a 0.8 millimeter sized round burr. So your entire drill size inside the root, inside the canal system, is about 0.8 millimeter. And that's why the accuracy is very important. When you go down from 100 microns to 50 microns, that's 50% more accuracy, or 100%, depending on where you're looking at. Every little micron will make a huge difference on whether you're gonna be right on top of the canal, off to the side a little bit, and if you're gonna find it or completely miss it. So how do we do the measurements? Now, the first 3 drills, they have a 0.7 millimeter, they have 2 wet. The bottom half will have a 0.7 millimeter in diameter, and the top half of the shaft will have 1 millimeter in diameter. So the way you have to plan it is you have to plan the end of your offset, or the top of the guide hole tube, to engage right at the 1 millimeter in diameter, and this will be free floating, because as you go deeper, this will act as your guiding plane through the guide hole tube to keep your drill centered inside the tooth. So we do not depend on this area here. We only depend on the 1 millimeter diameter top half of the drill to act as our guiding plane. Now, the 3 millimeter difference between the 31 millimeter long drills and the 34 millimeter long drills is actually in the length of the shaft that goes inside the handpiece. So that section of the drill is longer on the 34 millimeter, not in down here where the drilling part. So this is constant through the 31 millimeter and the 34 millimeter depth. So as you go deeper, there comes the necessity for a second guide, because the first guide we can create it with a 1.1 or 1.2 millimeter diameter guide hole to accommodate the 1 millimeter wet drill. But as you go deeper, now you're going to have to engage the actual shaft until you bottom out on your handpiece. And this is 2.3 millimeter in diameter, so you can print a guide, and the second guide hole tube can be 2.35 or 2.4, something like that, to accommodate it and keep it centered. And this is how it looks. You can see this is the short drill, and this is the long drill, and the difference is in the actual shaft that goes in the handpiece. So 3 millimeters is a big deal. It makes a big difference. Some of the cases that I locate the canals, I locate them 18 to 20 millimeters deep. A couple of them, if it's only going to be like within 15 to 17 millimeters deep, then you can use just one drill, one guide. If it's going to be over 17, 18 millimeter, then I would suggest to make the second guide and use the longer drills. So when the long drills are attached to a slow speed handpiece, the maximum total drill depth will be 20 millimeter if you engage the shaft. So you have to accommodate this size. This is, remember that patient we deviated from a little bit. So this is an intraoral radiograph as I initially popped into the canal with using the drill, and I found it. That was my first file in, and then I was able to negotiate it and get to length. And this is my master cone and the final treatment outcome on that tooth. Now, traditionally, our access would never be that small. It would be much larger than this, and we would sacrifice a lot of tooth structure, both coronally and cervically, until we get to hit that canal. Now, these are intraoperative pictures that would, put all this together for you. This picture up on top here, this present the case before I even started drilling. This one with the guide on, showing the guide hole tube extending from the top. And this is actually a video of the actual drilling through that tooth. Now, as we're watching this, watch minute at 3 minutes and 30 seconds, I will pop into the canal and you will see it clearly on the video. Right now, I'm just getting my initial access through the tooth. I'm putting a lot of pressure on the handpiece. I'm using actually a high-speed handpiece, not high-speed, a slow-speed handpiece running at about 8,000 RPM. This is how small my access hole is. It's not, you don't need a traditional big access, lingual access to get into the tooth. Using guided saves a tremendous amount of tooth structure. The limitations of drilling through this is um, you have to clear your path from dentin chips. Otherwise, you can pack that dentin inside the canal and ahead of your drill bits, and you end up blocking the canals and not being able to negotiate it. So one of the steps needed, and actually very important, is you drill a little bit for a few millimeters, take it out, rinse it off, and clear the dentin chips. Go back in, drill a couple more millimeters, and then clear the chips again. So now I'm getting to the depth of the short drills, and I can't go any deeper on the short drills with this. Again, go back, clear the dentin chips, and clear the path to the canal. This is how big the access hole is. I'm using the third drill, which is the 0.8 millimeter size round burr. Unfortunately, you cannot do this with the rubber dam placed on top, and that's why you have to drill through it like this without the guide so you can fit the guide properly. Now I'm using the second guide, and that would allow me to go deeper with the longer drills and gain at least another 2-3 millimeters deeper. I'm clearing the dentin chips, opening it up a little bit. I'm sorry for the scratch on my mirror, but you can see all the way to the bottom of the drilling path. Replace the guide again, and then you can go in as deep as it would allow you. And that normally the long drills honestly would see here, right here, that dip, that was me popping into the canal. Again, go back, clear up the dentin chips from inside. And once you get to that step, you verify with the file that you got into the canal, and take your mess and then apply your dental dam and start the regular process of a root canal. You would still have to enlarge your access a little bit after this, but not as much as if we were going in trying to locate the canal. In order to debride the chamber entirely, get your solutions down, disinfect the canal properly, and get your obturation materials to length. Michael, are we okay with so far? Any concerns or any questions?
No, so far we're good. Everything's
Perfect.
coming through well.
So this is my first file in just verifying that I did pop into the canal, and I'm on the right path. So these are intraoperative pictures. You can see how small this access hole is. It's a 0.8 millimeter access hole that, you just enlarge it probably to a 1.5 millimeter just to get your fluids in and perform the endo treatment properly. This is how it is. And then once you get your canals, you apply the dental dam, um, you negotiate the canal to length, and then you enlarge it a little bit and perform your regular day-to-day endodontics. Now, this case came to me. It was initiated by another endodontist actually. She's a 31-year-old female. She was referred to in our office for a second opinion and to attempt to treat tooth number 8. Treatment was started by another endodontist. They could not find the canal, and obviously you can see why. Complete calcification of the canal. Um, Look at the amount of tooth structure that was damaged and lost finding through the canal. And believe me, it looks really bad on the CT scan, but clinically it wasn't bad at all. It would have this is would be within normal of what we would do going in blindly trying to find the canal. Patient requested internal bleaching, which was her original chief complaint. And of course, at this point, we had to find the canal and perform the endodontic treatment prior to doing the internal bleaching for her. So these are preoperative radiographs showing the calcification, the extent of calcification inside the tooth. This is when the tooth was started. They had started internal bleaching. This was a composite seal and some calcium hydroxide in there. Again, these are the slices on the CT scan showing the extent of the damage inside the tooth and sacrificed tooth structure, trying to find that canal. This is a coronal section. You can see how much loss of tooth structure that was gouged and cleaned and taken out. And this shows you the extent of calcification inside in comparison to the neighboring teeth. This is the first slice where you can see the beginning of a canal or the entry point where I would have to plan my drilling path all the way down to this slice to be able to get to that canal. Again, plan the case in Blue Sky Plan. Create, this is my guide hole tube, and you would want to place it directly on the incisal edge, minimize the offset as much as possible to maximize the drilling depth that you can drill through, and at the same time minimize the deflection that's going to happen as you go deeper inside the canal. Again, you have to create two guides with two different diameters. One is for the shorter drills, one is for the longer drills if you're going to go higher or deeper than 17 to 18 millimeters in there.
Can I just jump in a second? For people that
Sure.
are a little less familiar with Blue Sky Plan, even though you're creating two surgical guides, the export fees only counts as one credit, one export. So the second guide with the different parameters could be exported from the software for the same case without any additional fees.
True that, yes. So the Blue Sky Plan is an amazing software, and it is available for free to download. And you can view DICOMs on it. You can play with it all you want. The only time the software or Blue Sky charges for anything is when you export an STL file out of the software, which is the file needed to print on a 3D printer, and that's the only time you get charged by the software. And Blue Sky Bio has been very gracious about this. They only charge you one export fee per case, and regardless of how many exports or how many STL files you export out of the case. And in a case like this, even though I printed two guides, I only got charged one STL export fee. And you can buy those when you have the software. You go up to the cart and you can purchase these online, and they will automatically populate your software, and you'll have those exports count. It's a countdown basically. When you export, it'll charge you. Um, Other than that, it's one charge per case. Now, so I created two guides for that patient as well. Those are the try-ins, making sure everything fits properly. And this is a video for this case. So in this case, it's going to show later on. But what I did, I went in and I actually rebuilt the entire central portion of the tooth with composite to strengthen the tooth and make up for all the lost structure. That composite in the center not will only just restore the tooth to its normal, not normal, but at least strengthen that cervical area of the tooth, but also will allow for my drills to be centered all through the process. And as I drill through the composite, the planes or the walls of the drilled area will act as an internal guide of my drill as well. Again, I was able to pop into the canal. This is my file using balance force technique to negotiate the canal to length. And this was my first file popping through. And using longer files. The first gray file is a C plus file, and it was a 21 millimeter long. So the depth was 20. That's when we pretty much popped into the canal. These are 25 millimeter long, size 6 file. And that will have, this is my Rudzi X trying to verify depth, and I'm a little bit short, so we're still negotiating the canal, trying to get to depth. These are Pro Taper Gold files that those are my to-go file in my practice. I love them, and they clean very, very, very well. This is my access hole with my canal prepared. This is called the agitator, or it's like a vibrating instrument that we use to agitate sodium hypochlorite and EDTA inside the tooth to increase cleaning and disinfection. Paper points, dry it up, and then placing my master cone with the sealer. Pump the sealer a little bit in there. Make sure you get it all the way down to the apex. And you finish your root canal regularly. So this was my first file. This is almost to length. This is my master cone gutta percha. Now, this is the final. Now, notice how irregular this is in the center area here. Remember, I filled this all with composite, and I did not want to over prepare that central area again. There was enough damage done to the tooth. I did not want to prepare any more than that. I stayed centered on top of the canal, and everything else was filled back with composites and sealed. That's why it looks irregular and not uniform. But this is all composite in the center there. These are some x-rays showing the buildup of composite in the center and my drill path. And this is more of a close-up. And this is the finalized, this is the access path. This is the finalized gutta percha at the level, at CAJ level. And that's it for that case. Now, what can go wrong? So far, I showed you two tough cases that would normally take me an hour at least to find a canal, and another one that another endodontist couldn't even find it. We're going guided. What can go wrong, right? A lot can go wrong if you're not very careful, especially in endo, because a little bit of deviation or a little bit of over drilling or with implant surgery is not really critical. Any deviation and or any irregularity in your drilling path in endo can lead to perforation. The problem is with endo, we are limited to the inside of the root. And as we go deeper and deeper, the root gets narrower and narrower, and our room for error gets smaller and smaller. And the problem is the longer the drilling path, the deeper you go in the tooth, and the longer your drilling path, actually your deflection is exaggerated and your margin for error starts to go higher. And so we have to try to, in your pre-planning, you have to pick the canal as high as possible to minimize the depth, and to try to minimize deflection and errors. So this is a case where it went bad on me. I've been doing guided access for like this cases like this for about 3 years. I'm very confident that I can repeat my success on every single case. I did that plan. I planned this case for a 72-year-old presented with pain and discomfort for upper front teeth. He was wearing an RPD. He wishes to save his front tooth at all costs because he doesn't have that many teeth left. And a CT scan showed complete calcification of the entire canal system. The first sign of anything was right at that level down there in the apical, probably 3.5 millimeter. And this was kind of like a void more than a canal. And you couldn't see anything beyond that again. Again, planned it in the Blue Sky Plan software and created the surgical guide. Now, as you're planning it, not necessarily you're always going to be centered on the tooth. Your most direct line to the entry point of your canal sometimes may become a little bit deviated, and you come off to the more to one side than the other instead of being in the center. And you can verify this by looking through the different slices of the scan on the software. The canal entry point was at 20 millimeter depth, which is as deep as I can go with even the longer drill on the Muntz burrs. And that's why the limitations on these burrs are significant. So even my long drills may not get me to the entry point on that canal. So these are the preoperative x-rays showing complete calcification of the canal, the periapical lesion that's there. And I had to drill through porcelain fused to metal crown through the tooth to be able to get down there. I started drilling using the surgical guide. I took an x-ray, verified I'm still centered in the middle of the tooth. And then I drilled a little bit more, and then I put my first apical file, and it showed that I was perforating mesially through the apex. Now, I probably started deviating right after I checked my my centered X-ray with the Muntz burr. I wish I had stopped and checked it again. That sometimes is overconfidence and believing too much in what you're doing. Certain cases you have to just verify and verify and verify. And this is my master cone. I'm trying to obturate the canal to length, at least to the perforation area. And I thought, I can get it properly sealed and just hope this will work and just be fine. The issue is when you perforate through the side of a root, your canal is not tapered anymore. And if you do vertical condensation like most endodontists do, as you do vertical condensation on an apical perforation like this, you're going to end up with problems, and I'll show you in a second. So this was the surgical guide in place. This is my access hole. This is my access hole inside the metal. In order to do this, what I do first is I use my Muntz burr and kind of scratch the surface of the metal of the crown or the porcelain, and then use a high-speed round burr, pop right through the metal just in that area, and then put my guide again and start drilling through it with my Muntz burrs. And that's what happens when you try to obturate vertical condensation. I'm not proud of what happened. I just have to show you what could go wrong even when you're supposed to know what you're doing with these cases. I got probably about a 4 or 5 millimeter gutta percha overfill through the lateral perforation. So what I had to do is I had to go in surgically, clean it up for the patient, and seal the perforation defect, and do retrofill and seal the original canal. A lot of times, even though you may have severe calcification all through the canal, you can still see it and pick it up apically, because calcifications normally happens coronally towards the apical area, and that's why we can find the canal more apical than coronal. This flap design is called papilla base flap, and we only use it in aesthetic areas. You can actually use it anywhere. It's a beautiful flap. You will never ever have any recession with this flap. You just have to have a healthy, thick, keratinized gingival tissue in that area. And we do not use it if we're suspecting a crack or a fracture, because you can imagine you cannot evaluate the sides of the tooth if your papilla is still intact there. So I went in. This is my surgical crypt. Did my epicoectomy. You can see my lateral perforation there and the original canal up on top. Those are the two prepped for retro prep, and I use BC putty or MTA putty to seal the apex and the perforation. Any questions as far as, or any concern as far as the regular endodontic access guides?
Yeah, a couple of questions came in. First of all, there was a question where the burrs could be purchased.
The burrs can be purchased online. You can just Google Muntz burrs, and it will take you to a website where you can purchase it directly from Dr. Muntz, the creator, or you can purchase it through your regular dental supplier like Pearson Dental, Patterson Dental. They carry them, and hopefully Blue Sky Bio can carry it online for us in the future. But actually my hopes are to work with Blue Sky Bio on creating a kit that would help avoid the limitations of those drills, because again, those drills are great up to 15, 17 millimeter. Anything deeper than that, you can get into trouble easily, and there's a lot of limitations to what they can do. So you have to know and understand the limitations of your drills before you can use them. But they are readily available to purchase.
Okay, and how long could those burrs be used for, or how often could they be
those
used?
are actually very, very, very good burrs and very stiff. And I would say you can probably use it 10 times at least before you can throw them away. And again, like I said, they come in a set of 6. You only need the first 3. So you can purchase the first 3 or you can purchase all 6.
Okay. Somebody was asking which CBCT machine are you using?
I actually use the Sirona Orthofos SL. And I used to have the Carestream. I love the Carestream. Their definition is amazing. I know Blue Sky Bio carry the Carestream machine. Um, the only reason I switched to Sirona was they came up with the ease of use. The Sirona machine was for my staff. It seemed to be very simple. Just a patient just bites on a bite plane, stick their head in there. The machine just centers the patient and just press a button and you get the scan. My staff were not my experienced staff that used to take my CT scans had left, and it was time for me to upgrade my CT scan machine, and that's when I started looking at the Sirona and I got the one. But actually, the Kodak, the Carestream software, you actually their definition is down to 0.76 millimeters, and the Sirona is about 0.86. So with the Carestream, you get a little bit more higher definition, but and less scatter for some reason. Their software shows a little bit less scatter on the Carestream. Orthofos SL, before the Orthofos SL, it was not possible to do endo with them at all. The Orthofos SL has a small field. It's a 5x5. The smallest field on the Carestream is 3x3. And they now have a built-in software to eliminate scatter or reduce scatter, almost as good as the Carestream machines.
Okay, here's a related question from Dr. Ryan Rupert. I have trouble visualizing small or calcified canals on my CBCT machine. Any tricks or settings to best visualize small anatomy?
Just like think of the CT scan exposure just like as if it's a regular X-ray. So you increase your kVp, you decrease your milliamps, and if you have an HD or a high definition setting on the machine, then use the HD setting. Now, for endo purposes, we would prefer to use the smallest field possible. That will give you the highest definition possible. But you would compromise the fit of the guide if you don't take a full arch scan. So you kind of need 2. One to give you the highest definition, one small field give you the highest definition to visualize the canals and make your planning, and another one that would be a larger field so you can get cross arch stabilization with your surgical guide. Otherwise, if you use a small field to create your guide, it's still accurate, but there's a higher chance of losing your accuracy with the cant because you don't have bilateral accuracy from the other sides on your guide. And that may, as you go deeper, it may affect your accuracy and staying centered on your path. So smaller field, high definition, higher kVp, and but you're going to need one for planning and one to create the guide.
Okay. We could probably work out a process flow in Blue Sky Plan where one scan could be used for the planning, just like you were saying, and then brought into another case, in order to properly create the guide, or even in the same case, actually, with the model, we should be able to do it.
Sure. So everything is just like you're planning for an implant. You need the CT scan, you need an intraoral scan or a model scan or a model DICOM import into the software. You need to merge those two to create as accurate as possible because you create your Endo Access Guide or your surgical guide on the STL file, not the DICOM files. And you just, as you plan, once you plan it, you go to create the guide, and you create your guide normally. And your outline, I would extend the outlines at least, like if you're working on a central, you would create your guide from first premolar to first premolar. If you're working on a premolar, you would extend it at least 1 or 2 teeth distal and all the way to midline to, or at least to the canine on the other side to get cross arch stability. Did that answer the question, or?
Yeah. Okay. There's another question that came in. Is metal sleeve needed for the use of the burrs? I noticed that the tube guide was becoming wider during the drilling, allowing the burr to wobble a bit.
True, but remember when I was showing the picture of the 3 drills, the 3 first drills, and their drilling shaft, part of the drilling shaft is the 1 millimeter in diameter. That stays 1 millimeter in diameter throughout the length of it. So as you go deeper, that 1 millimeter binds, remember, the binds in the walls and act as an internal guiding plane within the tooth itself, and it helps you stay centered. Now, if you, as you get deeper, now you may start deviating sideways, so you stay centered within the tooth, but you're deflecting off the path. So that's how I end up with the perforation in the last case. But yes, the actual internal surface of the tooth somewhat creates an internal guiding plane as well as you go deeper.
Okay, those are the questions that came in currently.
Perfect. So now we are going to move forward with the surgical guides for epical surgery for endodontics. This is a case that was done on the mesiobuccal root of tooth number 3. You can see that tooth right here, previously treated. Everything else looked okay except of a small lesion right on the mesiobuccal root here. I'm sorry. Right on the mesiobuccal root. Small lesion, looks very close to the sinus area. The other 2 roots are fine. So we wanted to do as conservative as possible. Normally, to get into and find that apex there, you know, I would be drilling quite some time to get to the canal and the apex and do my epicoectomy, and we end up with like probably a 10 to 12 millimeter surgical crypt. So I decided to do this guided and see how that's going to go. So with epicoectomy surgical guides, you have to take your impressions unless you have one of the newer intraoral scanners, and you can take an extensive amount of soft tissue all the way up to the mucobuccal fold accurately. Intraoral scanners will not work in this case. You would need to take an impression that shows all the way up to the mucobuccal fold, almost as if you're taking it for a denture with border molding, because the apex of the root is somewhere up there, and you have to reflect your flap all the way up, and so you can slide your surgical guide up there. So basically what we do is we create the surgical guide with an implant or a custom implant pointing towards the apex of the tooth. So you design it in the software, and then you create the guide and you print it. This is a pre-operative and a post-operative x-rays. So what happened is the reason why this root canal, even though it looked good, failed. There was a long isthmus between the MB1 and MB2, and this is the level of the retropreps and the isthmus filled in between. So look how small that access cavity is. This is my first drill in there, probably about a 3 millimeter in diameter. This is my final drill size. I used a 4.8 millimeter implant drill, and by the time I was done with this, my epicoectomy was done as well. See this, get a Persia point here, and there's the other canal there. Um, so when you do it, when you do epicoectomy guided, you can plan it in a way where it will create your surgical crypt and do your apical resection of the 4 millimeters that you need at, with one drill. The only problem with this is most implant drills are not made to cut through dentin and to structure like this, and that creates a problem there. I'll show you another case later that will show you why it's tough to drill through with implant drills. So this is the surgical crypt after I finalize it. Um, Over here, even though the crypt is very conservative, it's 4.8 millimeter in diameter. We still have to enlarge it a little bit to accommodate our ultrasonic tips to go in and do our retro preps and retrofills. Now, understand something. I've helped some people try to do apical surgeries like this, and when they did it, they did not do a retro prep and retrofill and did not seal the end of the root. As we cut through the apex and perform our epicoectomy, we're exposing a lot more dentin tubules, which create path for leakage into the canal system with the epicoectomy. So in endodontics, most endodontists, we would never resort to cold burnishing or just epicoectomy without having to place a retrofill and retroprep. It's very imperative that you do this. Otherwise, you have almost a 40, 50, maybe 60% chance your epicoectomy is going to fail because you did not seal the apical area of the canal. So this is after I enlarged it just a little bit, not much, maybe 0.2, 3 millimeters to about a 5 millimeter crypt. You can see both canals after the resection, and you can see that white line in between. That's the isthmus in between, and this is at higher magnification. And then retro prep and retrofilled. In this case, I used Super ABA, and this is I used PTFE to close my flap. In this case, I used a reverse semi-lunar incision flap pointing upwards, and I pulled my flap up, and when I slid my guide inside, it acted as my retractor and kept my flap pushed up. This is the video for the surgery. Now, I wanted to show you another video for apical surgery. So this one is being played at very high pace. I hope you enjoy it. So this is my flap, my retraction. I'm sliding in my guide, and you can appreciate the fact why you have to take your impression all the way up to the mucobuccal fold. In this case, I used Straumann guided surgical kit. I'm using my first drills, and I'm using the keys. Keys is a pain in the butt. If you can, in my other surgeries, I switched that into using the direct cut drills from Blue Sky Plan and using the metal sleeves instead of having to switch keys all the time like this. So this is the green drill, which is the 4.8 final size, And that's finalizing my crypt and my epicoectomy. That's it. A 4.8 millimeter surgical crypt with the epicoectomy all finished and done. Sorry for the shaking. It's because it's magnified because it's on high speed and it's through the microscope. Well, um, you can see the two canals, the isthmus in between, and right now we're doing the retro prep with ultrasonic tips, checking the preparation, and placing the Super BA retrofill inside. Then I polish, remove the excess of the Super BA after it sets. This is a composite polishing burr, so I am not cutting any more on my root surface. I'm just removing the excess of the Super BA. Now, this is a second case that I wanted to present to you guys. This is a lower molar and tooth number 19, and there is a big lesion on the mesial root and a smaller lesion on the distal root, and we decided to go in for apical surgery. You can see the two roots here, and you can see how wide this is. I'm suspecting a possible isthmus between the two canals in the mesial as well. This is the lesion on the front root. This is the inferior alveolar nerve canal. And the way you plan it, see, I have to plan like an implant placed at the apex. To the apex, you can't go straight sideways like this and make it flat because your mucobuccal fold is somewhere up here, and also it will be very difficult to get your drills flat and straight into the guide like this. So you have to have as low a steep as low of a uh, tilt to the implant as possible. The way I plan it is the end of the implant, half of it on the tooth, half of it on the bone. So by the time I'm done drilling through there, I have my 2-3 millimeters epicoectomy there. I just finish it up, and I have my 2-3 millimeters cut in the bone as well, creating my crypt, and that will also allow me to stay away from the inferior alveolar nerve canal. This is how the two implants looks like when by the time you're done planning them on Blue Sky Plan. Again, your impression must include the mucobuccal fold as high and as much and as deep as possible. This is the guide created in Blue Sky Plan, and I did that case with using metal sleeves and direct cut drills from I believe these were the Quattro direct cut drills. This is the guide fit in the patient's mouth on the day of the surgery. I love the accuracy of the Moonray. Those are the two guide holes with the sleeves inside. And this is my surgical crypt after I was done. The patient had a fistula, and the fistula was opening up in between the furcation. So by the time I cleaned up the entire lesion, we lost the bone in the furcation there, and we had to graft and place a membrane for guided bone regeneration. This is my epicoectomy completed. I finalized it after using the drills a little bit. I'm going to show you a video in a second. And that shows, again, two distal canals very close to each other. The two mesial canals with a long isthmus in between. And at this point, when I took the pictures, the entire crypt was degranulated and all the tissue was removed and it was submitted for biopsy. But once you clean it like this, it not just become an endo lesion, it's an endoperio lesion, and an endoperio problem, and you have to not just think as an endodontist, you have to think as a periodontist as well, and be able to regenerate bone in the furcation there. To control hemostasis, to keep it as dry as I can show here, I use two products. One is Hemodent, everybody knows about it, but that is for minor bleeding, for really strong control. There's a product out there, it's called Cutrol. Not many people know about it, but it works amazing. And the way I do it, you have new gauze strip, you cut about an inch piece of the strip. Do not use the iodoform impregnated new gauze, just get it plain dry, and you dip it in the Cutrol, and then you lay it inside the crypt. You'll see how I do that in the video in a few minutes. Once you have hemostasis and control, you start doing your epicoectomy and your epical preps and your retrofills. These are radiographs. The one on top on the right there, it shows the preoperative X-ray with the periapical lesion right there. And this is right after the apical surgery was done without the bone graft placed. This up here on the left shows the bone graft placed, and the membrane was placed as well. So this is our last slide and our last video, and after you guys watch this, we can have some more questions. So I'm using the Blue Sky plan for the direct cut drills for the Quattro. The front root is much skinnier, so it was easier to do the epicoectomy this way. But I'm putting a lot of pressure on the direct cut drills. The direct cut drills were not meant to drill through tooth structure. It's meant to drill through bone. And as it hits the tooth structure, you can see right there, I'm putting a tremendous amount of pressure on the drills, trying to cut the root as well. I was able to do it on the mesial. I was unable to do it on the distal. The best thing I could get on the distal is I drilled through the bone, got to the buccal surface of the distal root, gouged it a little bit, but I was unable to drill through the root at all. So we need, actually, I have designed a better suited drills for performing this and be able to drill through the roots as well, fully guided. Now I'm almost standing on top. That dip right there, that was me uh, cutting through the root and reaching the lingual wall of that root and a little bit of bone. So your depth control should allow you to stop almost immediately, within a millimeter, right past the lingual wall of your root that you're resecting. So those are the surgical crypts after using the direct cut drills. You can see the mesial root is completely resected. The distal root, you can see the surface there. I just barely gouged it. So after that, I have to go in and perform my epicoectomy on the distal root. This video is about 40 millimeter long, so I'm gonna jump through it a little bit. So here I'm finishing my epicoectomy and enlarging my crypts a little bit. You can see up on top here, that is the fistula opening up through the furcation. Still working on the epicoectomy. Now here I'm cleaning up the lesion. and trying to remove the fistula and the granulation tissue from the furcation. I had to join both crypts because I could not see the mesial surface of the distal root because of the way the distal root was inclined. Pushing the fistula and the granulation tissue down. Originally, I was trying to preserve that band of bone as much as I possibly can, which actually increases your success rate for fixing a furcation like this. But there was so much granulation tissue, I had to sacrifice it. This is opening that band of bone and clearing it so I can go in with my curettes and remove all the granulation tissue from inside. Now see this here? That is the root tip of the distal root, and I'm removing it. The nice thing, if my direct cut drill had went through the root, this would have been eliminated. What I did is I went to the top border of my gouge on the root, did my resection, and that allowed me to separate the tip of the root and stay away from the inferior alveolar nerve, that which was close towards the disc. It was far from the mesial root, but it was closer to towards the distal root. And I'm verifying with my retro mirrors there's no cracks or fractures on the tooth, and make sure that I cleaned out all granulation tissue. Here, I'm gonna bring this back just a little bit. So this is the new gauze strip that I told you guys about. I'm sorry. Right there. It's impregnated with, it's dipped in the cut roll. And the nice thing about this is some people use bracelets and cellulose pellets. You can forget them and leave them there, and they cause tissue irritation and the postoperative edema. The new gauze is packable. You can push it in, it stays in place. And when I'm doing my retro preps and retrofills, any debris will fall on it, and at the end I just pull it all out in one piece, and it brings out all the dirt with it. So you pack the new gauze strip inside with the cut roll. It stays in place, keeps everything nice, clean, and dry for you. I go in with my retro tips, ultrasonic retro tips, and do my retro prep. And at this point, I'm prepping the second canal, and I'm prepping the isthmus as well. Packing the gutta percha down, make sure all the prep is clean. Now we're going back for the distal canals. Now, when you're using ultrasonic tips like this, when you dip it in the gutta percha, the gutta percha should flow out like this, and you shouldn't feel resistance to your ultrasonic tip. If you feel resistance, you're going in the wrong direction, and you're actually creating your own canal or gouging in the root surface. Placing, this is BC putty, which is MTA putty. Using retro pluggers to pack it in. Oops, sorry. One second. Ah, yeah, I did it again. There you go. That's an easier way. So I'm cleaning the excess of the MTA. See, all the debris falls on top of the gauze, and nothing will stay inside the crypt. I'm removing the new gauze, making sure there's nothing else in there. Checking, make sure everything is clean in the crypt. Finishing and removing excess of the retro prep and the retrofill. And you can see now both canals in the distal filled, both canals in the isthmus and the mesial filled. Degranulating, make sure there's no debris. And actually at this point, I'm re-stimulating bleeding again because I'm going to place my graft inside, and I wanted the blood to hydrate it and get inside the graft. Thank you for listening. Thank you for joining us today, and hopefully that was informative. If you guys have any questions, I'll be more than happy to. And if you want me to go back to any specific slide, just let Michael know and we'll do that.
Okay.
Michael?
Yeah, if you have any questions, please submit the final questions. Meanwhile, just a reminder, I reposted the link for the webinar attendance form. So put in your details there so we could send you the CE credit. A question that came in previously, if you've ever used the SIC drill set for this.
The S-size drill set?
SIC drill set. Are you familiar with it?
No, I'm not.
Okay.
Is that for epical surgery or access guide?
The question came in earlier, so I believe it's probably
earlier?
connected
Yeah.
to the access guide.
Any other questions?
I think that pretty much takes care of it. I mean, our time is pretty much taken
went
up.
over, sorry.
That's fine. It was a fantastic presentation, and thank you very much for taking the time to present it and putting it together. It was a fantastic and informative presentation. Let's take one last question and then we'll wrap it up. When do you decide to do retreatment or an episiotomy?
Episiotomy?
Yeah.
Okay, so I don't do as many epical surgeries as I used to. Actually, when I first finished my endo residency, my plan was to open a surgical practice. I was not going to do root canals. I was just going to do epical surgeries and endodontic surgery all day. But actually, with the new advancements in instrumentation, files, microscopes, ultrasonics, all what we can do conventionally without having to resort to surgery, our success rate in retreatments is actually pretty high. I would say, up in the 90s, 85 to 90% success rate on retreatments. A lot of time, if it's multiple roots, like for example, an upper tooth, and you have root canal failed because it's the original root canal was not done properly. Now, if I go in and do an apical surgery on a previously treated tooth with a poor existing root canal or with coronal leakage, my success rate in apical surgery would drop immediately from the high 80s and low 90s on an apical surgery down to 60%. The reason is you did not get rid of the source of the problem. The apical surgery and doing the retrofill will seal the canal, will eliminate the ingress or the egress of irritants from the canal system and it will allow it to heal for about 5 to 7 years. But then we see these cases fail again between 5 to 7 years, as you know, the materials that we use for retrofill starts to degrade, and then what was trapped inside the tooth starts leaking outside again. I would only go to apical surgery in cases where it's not feasible to retreat, or for cases where they just had, like for example, I did the root canal, and I'm sure this was the best I can do as far as conventional root canals, and I'm suspecting an isthmus on the tooth, and I cannot fix that by going back and do the same thing again. I would resort to retreatments if you have a lesion on palatal roots. Those palatal surgery is not fun. I'm blessed that I have been trained to do them. One of the very few people that do palatal surgeries. Now with the advent of guided surgeries, I'm working on specific designs for palatal surgery using guided systems. But yeah, I would go for epicoectomy either on a freshly done root canal, well done root canal, and not feasible to do conventional endodontics. Otherwise, it's a retreat.
Okay, so let's wrap things up. There are a lot of comments coming in. Thanking you for the presentation. Very insightful. Great job. Great new ideas. Thank you very much.
Thank you. I appreciate it.
Sure. So I'd like to thank you as well, and I'd like to thank everybody who attended the presentation, and wish everybody a good evening.
Good evening, all of you.
Thank
Bye.
you very much.